Now today we'll be discussing a very interesting ECG. Now when we see the most important ECG part that we have to always see is the heart rate. Now how do you come to know the heart rate? It's very simple. We just see the RR distance and we take 300 divided by number of large boxes, or we take simply 1500 divided by number of small boxes. Small boxes means we see 1 millimeter, and large box means we take 5 millimeter box. So it's very crystal clear. Just pick any two. So this is R, this is R. In between the two, this is one large box, two large box, three large box, and four large box. So here the heart rate is around 300 divided by 4, that is 75. We again see RR here. This is R and this is R. There is one large box. There is this second large box, third large box, four, five, and around five and a half. We can simply take six as small boxes. So 300 divided by 6 is around 50. So, so the heart rate is definitely low. So in between the heart rate is less than 60. So whenever there is less than 60, it has to be either sinus bradycardia. Now the most important thing to call it as sinus bradycardia is each and every P wave must be followed by QRS complex. So if the heart rate is less than 60 and each and every P is followed by QRS, we call it as sinus bradycardia. Same way we can have first degree heart block, where there can be heartless can be less and the PR distance is usually more than 20 milliseconds, or five small boxes. So that is what is uh, the first degree heart block. In second degree heart block, we have Mobitz A and Mobitz B, or Mobitz 1 or Mobitz 2. In Mobitz 1, there is actually gradual prolongation of PR, and then it is followed by a drop in QRS. So that is basically Mobitz 1. And in Mobitz 2, the PR remains constant. The PR remains constant, but there is sudden drop in QRS. So that is Mobitz 2. So in Mobitz 1, there is basically gradual prolongation of PR. So the distance between P and the QRS complex keep on increasing. So there will be this, the PR distance can be like then this, and then suddenly you get a drop. There will not be any QRS. Then again, it follows the same pattern, and then there will be a drop in QRS. But in Mobitz type 2, the pattern will be the PR will be constant and suddenly there will be a drop in QRS. The PR will be constant and there will be sudden drop in QRS. So this is Mobitz 1 and Mobitz 2. And in the last, which is complete hard block, the RR distance is constant and the atrial, means the PP distance, is constant. And P can be present anywhere around R. So it can be above, it can be before R wave, it can be after R wave. So there is no relation between the P and the R wave. The relation is very commonly persistent in Mobitz 1 and Mobitz 2, but in this complete hard block, this relation is completely gone. What we call it as AV dissociation, means that P keep on coming at continuous the same timing, and the R keep on continuing at the same distance or same interval. So here we can see that there are some P waves where there is no QRS. So this is lead 2, and if we can see this lead 2, when we can see this lead 2, so this is definitely a P wave. This is definitely a P wave, but there is no QRS. So we know that PR distance is prolonged when it involves five small boxes or one large box. So in between P and R, maximally you can have five small boxes. If it is more than that, we definitely call it as prolonged. Now here, see, there are around five boxes. But here, see, there is only P, there is no QRS here. It means ki there is some block. It can be Mobits 1, Mobits 2, or it can be complete hard blocked. Now to call it as Mobits 1, there must be prolongation of PR, then only there should be drop. So we'll see whether there is any prolongation of P or not. See now here, the distance is hardly five small boxes. So, and it is directly dropped, means there is no prolongation at all. 5 is bare minimum to call it as prolonged. So it should be either like this, and then drop, then we can call it as Mobits 1. But here it is hardly 5 small boxes and there is direct drop in QRS. It means this is not Mobits 1 block. Now to call it as Mobits 2 hard block, the PR has to be constant. So now we'll check here whether the PR distance is constant and whether there is sudden drop in QRS or not. Now here we can see if the PR has to be constant. See, we can see there are around five small boxes. Here it is drop. Okay. We'll see other five other P waves. Now see, this is the P. There is no QRS or it looks to be very much prolonged. See, here is one P wave and there is no QRS. So this distance is around 10 small boxes. This is around 5 small boxes. Here it is around 5 small boxes. Here it looks to be around 8 to 9 boxes. Here there is P wave. There is no QRS. Here it is again 5 boxes. Here it looks slightly more prolonged. Here you can see is around 10 small boxes. So basically here there are 5 small boxes. Here it is not at all there. Here it is around 10 small boxes. So this PR distance is not constant. The PR is varying. It means that this cannot be Mobits type 2 block. So this is not Mobits 1, Mobits 2. It means that it has to be the complete hard block. Now to call it as complete hard block, it must fulfill the constant RR distance, constant AA distance, and there should not be any connection between atria and ventricle. So if you can see this distance, the PP distance, so there is around one large box, two large box, and around three large box. If you can see here, this is one large box, two large box, and three large box. If you can see from here, if we consider this as P, then one small box, two small box, and three small boxes. So here also, this is the P wave. So this is one small box, two small box, and around three small boxes. So the PP distance is remaining constant and the RR distance has to be constant. So uh, if we can see here, the in between the two R waves, like there is one, two, three, four, five large boxes. From here, one, two, three, four. There was supposed to be one QRS, but that QRS is completely dropped. There is no QRS there. And yet again, one, two, three, and four, 4.5. So basically, this is not a perfect complete hard block, but it is a varying hard block where there is one significant component of complete hard block. So this falls under one of the best example of complete hard block, and the reason is very very clear cut, as you can very nicely see that there is a prominent Q wave in lead through 3 and AVF, which actually signifies that there is involvement of right coronary artery. And you can very clearly see that there is ST elevation, which is very, very clear cut. There is ST elevation in lead 2-3 AVF, means there is inferior wall MI, which has been recent, and inferior wall is supplied by right coronary artery, and this right coronary artery actually supplies the pacemaker as well as AV node also. So in inferior wall MI, it is very common to have almost all types of block. And when the patient is in acute MI, when the patient has MI, when the patient has heart attack and is approached to the casualty, from during acute heart attack to thrombolysis or PAMI, or after post PAMI or after post PTC also, till the patient can have this varying degree of heart block, which may range from first degree heart block, second degree heart block, or third degree heart block. So within an hour, the patient may have all these type of heart block, which may continuously vary till the problem gets settled. So most of the time, if the patient is not having symptoms, this can be managed conservatively, and it has to be treated with either thrombolysis or best is PAMI, that is primary angioplasty for myocardial infarction. And most of the time, doing PAMI or doing thrombolysis and managing the patient supportively usually sorts out this complete heart block or whichever block this patient has. So this is a very interesting case with recent acute inferior wall MI, presenting with complete heart block and some portion of variable heart block. And that's all for now, and thank you so much.